that recording has started for this particular meeting. Thank you, everybody, for joining us today for our rate determination interested party engagement session. And this one is for clinical services, section policy 19, 20, 21, 40, 96, and 102. Next slide, please. I would like to start off by defining clinical services for everybody on the call. This includes counseling, assessment, screening, therapy, and other services that require specialized knowledge and training in the treatment of patients provided by qualified and credentialed staff, including but not limited to board-certified behavior analysts, licensed psychologists, licensed counselors and therapists, licensed and registered nurses, and physicians. Again, our focus today is on activities and codes related to clinical services as defined on this slide, which specifically fall under sections 19, 20, 21, 40, 96, and 102. We do understand there may be providers that provide clinical services under other sections. However, those may be being evaluated in another rate determination process conducted by Burns. For more information on other projects or sections of policy, please see the rate reform website. And we will also put in the chat the rate reform website. Next slide, please. So under clinical services codes that are identified for this rate determination project, we have identified with main care the following codes listed here. And there are 16 codes in total for section of policy 19, 20, 21, 40, 96, and 102. They're listed here. The first section, there's actually 2 slides, and I believe Amanda has put in the chat the link for all the codes that are identified that you can review. So 96, 156, 96, 158, 96, 159, 96, 164, 96, 185, 96, 167, 96, 168, G0156, G0299. Next slide, please. G0300, H0031, T1000, T1004 with 3 different revenue codes, T1023, T1502, and T2034. Those are the codes that we're identifying for this particular section and engagement session for today's discussion. Next slide, please. So our agenda during the next 60 minutes, we'll quickly review the rate determination process, overview goals, activities, and then we'll get into some questions and opportunities for discussion and feedback, and certainly have a wrap up. Next slide, please. For introductions, I'll introduce the PCG team, some of us on the call. Myself, I'm Rhonda Kern-Strelzer. I'm a senior advisor at behavioral health here at Public Consulting Group and lead the interested party sessions. Caitlin Crone is on our call, and she's a senior consultant, as well as Maddie Wall, a business analyst. We also have some of the main care team on the call today, so I'll turn it over to Kristen to make those introductions.
Thanks, Rhonda. Thanks, everybody, for joining today. My name is Kristen Merrill. I am a senior policy manager with the Office of Main Care Services and the policy unit. I'm joined today by a couple of my policy colleagues, Tom Leet, Heather Bingalis, and Megan Brooks. And I will pass it over to folks on our rate reform and setting team. Dwayne.
Hello, I'm Dwayne Parsons. I'm the acting manager of rate setting. I'm joined by Amanda Lee, our rate setting coordinator, Jennifer Morse, our HCBS rate setting analyst, rate reform analyst, and Jessica Levesque, our program manager or project manager for rate reform services. And I'll pass it over to Derek.
Thank you, Dwayne. My name is Derek Fales. I'm with the Office of Aging and Disability Services. I oversee the Section 102 Neurorehabilitation Program for adults with brain injury, as well as Section 20 other related conditions, and Section 18 the brain injury waiver. And I do see that my colleague Allison Toomey is on. And our other colleague, Nicole Rooney, who oversees long-term services and supports for Office of Aging and Disability Services, will join us shortly.
All right, thank you very much. We will go to the next slide, please. And this is where we're going to start talking a little bit about the rate determination process overview. Next slide, please. So while focusing this meeting, while this meeting focuses on feedback from participants regarding clinical services, I do want to highlight the process from a few slides on our kickoff call that we had at the end of August. The rate reform process sets schedules for regular rate reviews, benchmarking, creates a transparent process, and includes technical advisory and comments. Next slide, please. So steps for the rate determination process include a kickoff call, like I said, was held at the end of August, actually August 28th, and can be found on the rate reform website. Public forums for also includes public forums for feedback, official written comment period, which we will identify later on. It includes department review and final rate determination, which should be around April of 2025. So during this process, PCG will hold and conduct interested parties engagement sessions, collect data and complete analysis, develop a rate model, draft rates, and make presentations for comments. Also finalizing rates and publish those, as well as make final recommendations for consideration to main care. I also want to review a few items from an interested parties engagement standpoint. These meetings that we're having now are the first of general meetings to start gathering information, and we anticipate further meetings in the future with additional focus items and a survey to gather more feedback. In addition, we do have an email set up that you're welcome to send information, questions, or comments to, and we will put that in the chat as well. Next slide, please. So following the established requirements for the rate reform process, this project focuses on home and community-based services, including assistive technology, devices and services, care coordination, clinical services, which is today's focus and topic. Again, specifically focusing on Section Policy 19, 2021, 40, 96, and 102. It also includes supportive skill building, therapeutic interventions, and personal support services as well for this whole entire project. I do want to note other projects are occurring simultaneously with other partners in main care during the same time frame, which are reviewing other sections, payments, rates, and codes. So if you're not seeing a section listed here, check that rate reform website for other projects ongoing. Again, this section meeting will focus on clinical services. However, if you're interested in providing feedback for any of the other sections or services listed, we are having specific meetings for those upcoming, which are listed on the rate reform website in the kickoff presentation. Emails have also went out or will continue to go out through the listserv, and we will put the dates in the chat as well. And we will also put the listserv where you can sign up if you've not received that or not on that list. Next slide, please. So our project goals, are develop and document benchmarking, service definitions, rates, and coding alignment, engaging closely with interested parties throughout the whole project lifecycle, demonstrating the impact of changes to rates or service definitions, and ensuring alignment to state and federal reimbursement requirements. Next slide, please. So currently, I'm going to talk quickly about our project activities, kind of a little bit of an overview. We have identified codes and rates for each sections in conjunction with main care, and a list can be found on the rate system reform link. We have been analyzing codes up to this point. Our project actually began around May of this year. So we've been working on analyzing codes, identifying benchmarks, and looking at the services without benchmarks. We're also going to be creating benchmarks with input from providers, as well as creating assumptions based on best practices and national trends. So throughout this whole entire project engagement, we will continue to have engagement with interested parties, and also why we'll have additional sessions and gather additional information is because we need that assistance from providers or interested parties to help us create those benchmarks for any services without currently any benchmarks, like comparison to Medicare, for an example. Next slide, please. So as we get back to the questions and why we're here, I again want people to think about the first couple of slides we showed regarding the definition and the codes in which are part of this particular section. So with that being said, one of our first questions that we will have, please feel free to raise your hand, come off mute. Certainly you can put things in the chat or the Q&A. Any of those would be sufficient. So please feel free to come off and respond. So our first question is, what concerns do you have about this rate determination process that you would like the team to be aware of regarding clinical services? Give everybody just a few minutes.
Rhonda, could you go back a slide? I think when you were talking, that the slide may have been forwarded too early when you were going over the rate discussions, because this slide for the interested party questions has been up for quite some time.
Is it this slide?
Mm-hmm.
Okay.
But if you can go to the previous slide, I think you were talking, and it had already advanced to the question when you were still talking about these activities.
Do you want me to review this again, Derek?
If you could, yes, please.
Yeah, I certainly can. While this meeting focuses on feedback from participants regarding clinical services, I want to highlight the process from a few slides on the kickoff call and this particular one here. Amanda, I just saw that you mentioned you do not have access to the Q&A. We will make sure that that is turned on. It is on. Okay. Um, the rate reform process sets the schedule for regular rate reviews, benchmarking, and creates a transparent process that includes any technical advisory and comments, which are outlined here. Next slide. So steps for the rate determination process include a kickoff call, which was held 8/28/24 and can be found on the rate reform website, um, as well as other activities. Part of this process include public forums for feedback, official written comment period, department review, and final rate determination, which should be around April of 2025. During this process, PCG will hold and conduct interested parties sessions, collect data, and complete an analysis, develop a rate model, develop rates, and make presentations for comments, finalize rates, and publish and make those final recommendations for main care to consider. Also, I want to review a few items from the interested parties engagements standpoint. These meetings are the first general meetings to start gathering information, and we anticipate further meetings in the future with additional focus items and a survey to gather more feedback. In addition, we do have an email set up for, and you're welcome to send information, questions, or comments to. Next slide. Following the established requirements of the rate reform process, this project focuses on home and community-based services, including assistive technology, devices and services, care coordination, clinical services, which is today's meeting specifically focused on, which is section policy 19, 20, 21, 40, 96, and 102, supportive skill building, therapeutic interventions, and personal support services, which will be the focus of this entire project. I do want to note other projects are occurring simultaneously with other partners in main care during the same time frame, which are reviewing other sections, payments, rates, and codes. So if you are not seeing a section listed here, please check with the reform website for other projects ongoing. Again, this section meeting will focus on clinical services. However, if you're interested in providing feedback for any of the other sections or services listed, we are having specific meetings for those upcoming, which are listed on the rate reform website in the kickoff call presentation. Emails went out or are continuing to go out through the listserv, and we will also put the dates in the chat as well. Next slide. So our project goals are to develop and document appropriate benchmarking, service definitions, rates, and coding alignment. Engage closely with interested parties throughout the project lifecycle, demonstrate the impact of changes to rates or service definitions, and ensure alignment to state and federal reimbursement requirements. Next slide, please. So currently, our activities and things we have done to this point is we've identified codes and rates for each section with main care, and that list can be found on the rate reform link. We also have been analyzing codes, identifying benchmarks, and for services without benchmarks, we will be creating benchmarks with input from providers, creating assumptions based on best practices and national trends. And so throughout this whole entire project, we will have engagement with interested parties, and which will occur, and why additional sessions or information will be needed as this process continues. Next slide, please. So with that being said, again, our opportunity here and reason for having meetings today was to learn some additional information. Please feel free to raise your hand, come off mute, put information in the chat or questions. And our first question is, what concerns do you have about this rate determination process that you would like the team to be aware of regarding clinical services? And this can be anything in general, in regards to, um, not only the codes and services, but it can be anything in general that you would maybe have a question or something you would like for our team to be aware of, that may impact your service. I'll give another minute or two in case someone has a question.
I think it's me. I just wanted to note that I know that a lot of us on the main team can't access the Q&A, but I did ask people to introduce themselves in the chat so we could see if people could chat. But so I'm just trying to make sure that the attendees are able to come off mute or raise their hand or post in the chat so that we're able to make sure people can participate if they're trying to. If people can kind of let us know if you're having technology problems in some way, that would be helpful. Thank you. So I think that the Q&A isn't working for anyone, so I don't think that's probably the best way to communicate right now is what I was trying to say too.
Caitlin had just posted in the Q&A forum. Jessica, can you respond back to that?
So if I click the Q&A at the top of the screen, is there another way to do it? I guess that's what I'm saying is I click next to chat where it says Q&A and it doesn't allow me to access it. Which
Yeah,
is
I think
fine
it's the
if people,
same for, I think it's the same for the whole main team. It just says there was a problem reaching this app.
Yeah.
So I think to Jessica's point, if
technology.
If other individuals are experiencing the same problem, feel free to put comments in the chat or even just, try to come off mute or raise your hand. So PCG staff can give you access to come off mute if you're unable to, in order to provide your comments, feedback, questions, concerns, whatever might be relevant for your organization related to these clinical services that we're discussing today.
Right. Thank you, Kristen.
It looks like we have 11 additional individuals on the call right now that are attendees. If we do not have any concerns, we will go to the next question. We can certainly come back as well. The next question, are there specific codes or rates for this rate determination process where you think changes need to occur for clinical services and why? Anyone on the call have concerns or want to identify specific codes or rates for this rate determination process and where you think changes might need to occur in relationship to clinical services? Please feel free to raise your hand or come off mute, or you can put things in the chat. Oh,
Thank you, Susan. Just making sure that people can communicate with us is what my concern was going to be. And the raise your hand is at the top of the screen. Just trying to make sure that we're not moving on if we have questions. So thank you, Susan, for posting your name in the chat so we know that Christopher and Susan can communicate with us.
Is there anything that anybody would like to raise regarding codes or rates for this rate determination process for our team to be aware of, or something that maybe need to be changed, or something we should be looking into?
Would it be helpful, Rhonda, if we go back to those couple of slides or post it in the chat for people to be reminded of what codes we presented?
Yes, we could do
Thank
that.
you.
And I
'Cause
can
it
drop this
is-
in the chat for you.
Perfect, thank you. It's a large list. Christopher, I think you just posted something in the chat. Thank you for letting us know. It sounds like, and please feel free to come off mute. I'm just going to kind of paraphrase, but it seems like you're here to kind of learn more, is what I'm understanding. Okay, perfect. Thank you for responding. And this is part of the fact finding for us too, and starting to learn more from providers and interested parties to, start focusing in on certain aspects or pieces, or to hear, how some of the rates or the specific codes are for each individual service line, how that is maybe part of, something we really need to look at or focus on. So this is kind of our initial fact finding and gathering as well, Christopher. So we're there with you. And then Caitlin did post in the chat the codes that are being looked at under this particular rate determination for clinical services. And so with that being said, if there are any specific codes or rates that you think changes need to occur, or for clinical services, please let us know. Give another minute, and if not, we'll go to the next question. We can always go back as well, because sometimes other questions prompt other things, and that's fine. Okay, we'll go on to the next question. Next slide. Are there gaps in existing payment methodologies for this rate determination process to highlight for our team for clinical services? And in some of the other sessions we've had with other sections, there have been different things identified, like, staffing, for an example, or credentials, things like that. So it certainly could be anything when you're looking at payment methodologies, and how maybe that is impacting or creating a gap in existing payment methodologies. Are there is there anything regarding the existing payment methodology instead of saying gaps? Is there anything in the existing payment methodologies for clinical services that you would like to highlight for our team, or something that you want us to be aware of or think that we should know? Are there any challenges that are currently existing with payment methodologies that anybody would like to raise or bring up regarding this current rate determination process for clinical services? Okay. We will go on to the next question. As I said before, we can go back. That's not an issue. So if there's something that someone wants to bring up later on, that's fine. Next question, what do you think is the most valuable for our team to know regarding clinical services for this rate determination process? And I can give an example. You know, one of the previous sessions, it was identified for an example that there's a difference between care coordination and case management. So that might be something like that you want to highlight, like how there's a difference, or maybe, something that you feel that our team really needs to know or understand regarding clinical services as we go through this rate determination process.
I just wanted to ask in a different way, are there difficulties that you encounter when you provide services that maybe rates would improve?
Susan, thank you.
Hi, sorry, I'm backtracking just a tad.
It's
We
okay.
do have some concerns with the RN, the G0299 service code. So traditionally, that is a Medicare code. And we run into a lot of issues when we're trying to obtain insurance denials for private duty nursing, because when we submit the requests to private duty nursing, they're generally looking for an S code, and I think it's S9123 or S9124. I'd have to double check that, but I think that those are the codes that are traditionally private duty nursing. So oftentimes our nursing services are being approved by the private insurance company because they're confused. They think that we're offering short-term services versus long-term chronic services. So I just wanted to point that out.
Perfect. Thank you so much. That's very helpful information for us. And certainly something that we appreciate you raising and bringing up. How often are you seeing, or I guess, how often are you utilizing those codes?
So I would say 65% of our organization is private duty nursing. So we're utilizing it a fair amount. With that said, a lot of our clients do not have a private primary insurance. MaineCare is their primary insurer. We provide primarily pediatric services. So in any given year, probably just a guesstimate, roughly 15 children that do have private insurance through a parent's workplace. So MaineCare is the secondary. And so what happens is when we go to submit a request to obtain a denial from the private insurer, we're submitting that GO299. They're assuming that we're asking for the Medicare, the short-term skilled, because that's the code that appears to be universally used. That the insurance companies recognize, at least, in most states. Most states are using the S code for private duty nursing. So it creates a lot of issues trying to obtain denials, because we're actually put in a position where we're needing to then call I've only seen private insurance actually pay for private duty nursing services a couple of times in 15 years. It's almost never done. And so, but almost every single time that we try to obtain a denial, they are approving it. And then it's a lot of back and forth. We've tried doing electronic billing. Whenever we submit these electronically, they pay us. But then we're dealing with the issue of when they do their own audits and they recognize what the services are, then they're coming back and wanting to recoup their money. And I have seen one situation where an insurance company came back approximately 15 to 18 months after the fact, recouped their money, and then we were outside of timely filing. And so we lost all of that revenue for services that had been provided.
That is really helpful context for our team. Certainly to understand, the primary versus secondary insurance and how you guys are trying to work through utilizing these codes. So that is very helpful context. Thank you so much for providing that. That's certainly something I think is very valuable for our team, and also the specific codes, an issue with those specific codes. Are there other situations, Susan, that you run into with some of those codes?
The only issue that we have is with the group of RN, skilled RN. And I think LPN might actually fall into that as well. I think the GO 300 is also a Medicare. Typically, it's a skilled code for visits, like hourly visits, not typically used by private duty nursing. And most states are using the S codes, which is again where so much of our confusion is coming from. When we are dealing with these large insurance companies, they're recognizing this as a short-term skilled need versus something that's chronic in nature, even though they're asking for copies of 485s or plan of cares, which outlines like this is definitely long-term, 60 hours a week service. It's not connecting for some reason, and they're assuming that we're doing 1 hour visits or they're approving what we're asking for. Even though it doesn't theoretically make sense, there would never be a situation where Medicare or a skilled organization would do 60 hours a week of service. They get approved, and like I said, then after the fact, then they're coming back needing to take back money because it shouldn't have been approved. So I think it's the GO 299 with any of the modifiers, I think with the exception of school. And then the GO 300 is an issue. We don't really have LPNs, but it would be an issue because then again, as a skilled, it's a Medicare code.
Yes.
Those
Okay.
are the only ones I'm aware of.
Okay. That's very helpful context for us. Also, when we provide and I think it's already been out there once, but the email address where you can send comments, if you would like to identify those two codes that should be used more often that you're seeing, or maybe what you're hearing from the insurance companies, if you want to confirm that, if you would send that to us, that would be very helpful. And we'll also work on our side to make sure we're doing that research. But that would be very helpful if you could identify those and send it to the email.
Yes. Yep. We can absolutely do that, as well as any other questions that we can think of.
Sure. Perfect. Thank you so much. Appreciate you coming off mute, raising your hand, and being the first one. Appreciate that very much so. So with that being said, with Susan, anybody else on the call that would like to add or maybe identify, or maybe that's spurred another thought of something else that you would like to bring up regarding any of the questions we've already asked, or maybe codes? We can always go back, like I said, not an issue. If there's, we'll give it just another minute to see if there's anything else that people are thinking about out there that they would like to bring up to our team. All right, let's go to the next question. Is there any general concern that you would like to make sure our team is aware of regarding clinical services for this rate determination process? And for an example, I know something that was brought up, in some other sessions previously was about, changes with federal regulations or also maybe some changes in Maine's regulations or something that was going to be upcoming. And so that was brought up as well. So it can be anything general. It can be, wide as nationwide. It can be very specific from the state, or it can be certainly something directly related to clinical services and how you're providing care, or maybe what's impacting or challenging you when you provide care. Anything at all anybody wants to raise regarding general concerns that you may have regarding providing clinical services for this rate determination process? Give it another minute or two, or anything from the previous questions that we've identified or asked previously. If there's something else that you would like to bring up, please feel free to put it in the chat, come off mute, raise your hand. All right. Anything else before we go to the next slide? Or is there any other slides that we need to go back to? Or anything that we've not asked that anybody would like to bring up regarding this particular rate determination process for clinical services? All right, next slide, please. Again, here's our project email. I think it's went out in chat already. For any communication questions or comments that you might have, or something even after we get off this meeting, there's something you want to bring up, please feel free to email us at mainhcbscnc@pcgus.com. We will certainly take whatever comments or feedback, or try to help answer questions that we possibly can. Might also put it in the chat for everybody as well. Are there other questions, concerns, comments, or anything else someone would like to bring up before we would end this call? Okay. Well, again, please feel free to reach out to us and provide any comments or feedback that you might have regarding clinical services as we go through this rate determination process. As I said, we will be having other sessions in the future that may be more focused and specific, as well as surveys, or a survey would be coming out. So look for those. Again, if you need to sign up for the listserv so you can receive communications, that is out there. That's how all of our communications are coming through for any future sessions or project-related items. So please feel free to sign up for that and make sure that you can reach out or attend anything in the future. Before we sign off, I wanted to just check and see if there's anything else that any of the attendees would like to bring up, or questions or anything else that could be answered by the team here before we end this call. Okay, well, thank you everybody for attending. We appreciate it. Certainly appreciate the feedback as well. And hopefully we'll see you soon on another call. Thank you. Bye-bye.